This talk really is about how we can improve the management of people who have inflammatory heart muscle disease, essentially improving how we detect myocarditis, improving the accuracy with which we diagnose myocarditis, understanding how to predict outcomes, and of course fundamentally and ultimately in improving outcomes of people with cardiomyopathy, with myocarditis. And to do so, what I'm going to do is I'm going to talk about, I'm going to give an overview, an idealized overview, a sort of cartoon view of the pathophysiology of myocarditis, with an emphasis really on trying to develop a better understanding of how it presents, what our diagnostic tests can and cannot tell us, and understanding also a little bit more about prognosis and what we need to do better in the future in order to achieve that ultimate gain of outcome of improving a patient's outcomes. I'll also examine some of our patient presentations and pathways, and throughout the talk I'm going to be trying to identify lessons that are to be learned in order for us to achieve that goal of improving outcomes and developing new pathways. But the first question is why should we do this? We've heard a lot today about rare diseases, and if you look at the big data end of what we know about myocarditis, it is a rare condition. We're told that the data, at least from the Global Burden of Disease Project, that myocarditis is a very rare cause of death, but 1 in 20,000 deaths is attributable to myocarditis. It's also uncommon. It affects only 1 in 5,000 people. But I hope I'll show you today that this is likely to be a massive underestimation of the burden of myocarditis because it's not often identified and diagnosed. And certainly when we look at the clinical end of the spectrum, at what we see in our clinics and also on our post-take ward rounds, myocarditis is probably much more of an important condition. We've heard a lot about DCM, and the data here varies, but it's unquestionably an important cause of dilated cardiomyopathy. There's good evidence on the basis of a very high bar, or histological diagnosis, of myocarditis being a cause of DCM in at least 10%. If we look at less specific but more sensitive ways of detecting inflammation, and in this case looking at viral genome on biopsy samples, as many as 2/3 of people with DCM may have myocarditis as a cause or a contributor. And certainly when we look at this rare, fortunately very rare but catastrophic event of sudden cardiac death, up to 20% of young people with sudden cardiac death are diagnosed post-mortem with myocarditis, and we're seeing similar things in a wider range of people who've survived sudden cardiac death. What myocarditis means to most people, and certainly to me as a trainee and as a medical student, is this phenomenon here of fulminant myocarditis, fulminant heart failure, where a patient, an individual, goes from having a normal heart to being nearly dead within days, is unfortunately quite a rare phenomenon. It's difficult to know how common fulminant heart failure is. Certainly in an institution our size, we see perhaps 5 or 6 of these a year. In contrast, this phenomenon here is very, very, very common, and there are about between 3 and 7,000 normal coronary angiograms per year in the UK. These are people who present with chest pain, abnormal ECG, troponin elevation, something we've termed before as an acute myocardial syndrome. And MRI data tell us that up to 2/3 of these perhaps have evidence of cardiomyopathy. So we go from very common conditions that almost certainly have a very good prognosis to a real clinical problem here that we have very great difficulty in solving. And that's what we'll talk about today. This is that idealized cartoon of an understanding of myocarditis. This is based on observations from human studies, but also more fundamentally on basic science animal models of autoimmune as well as viral myocarditis. And it starts with a cardiotropic insult here, most often a virus. Jerry's mentioned autoimmune conditions already today. And there are other cardiotropic pathogens that include toxins and allergens, of course. That results in direct injury to the heart, to the myocyte, and also injury to the heart that arises from the innate and adaptive immune responses to those pathogens, resulting in all these things here. And I've put things in red that are detectable by our tests. And so in acute inflammation, these signals are quite florid, leading to functional abnormalities and other things that we can detect on imaging. And in the majority of cases, myocarditis heals and may leave only a little bit of scar, and sometimes actually no detectable injury. And our tests include these here. Easy to detect the pathogen because there's lots of it around. This is the gold standard diagnosis for involving the demonstration, direct demonstration of myocardial inflammation. This is an example of an MRI scan showing T2 weighted imaging, lots of inflammation in that lateral wall, and here in the healed case, a little bit of epicardial scar. So these tests are actually quite informative and altogether are probably very sensitive and quite specific. However, for reasons that aren't completely understood, but almost certainly involve the nature of the pathogen, the response of the host to the pathogen, but also the response of the host to myocardial injury, to the exposure of myocardial antigens, chronic inflammation can result. And this is best thought of as a triggered autoimmunity. Of course, there are other reasons that people can have chronic inflammation, including persistence of the virus or the pathogen. And here the chronic inflammatory story is a little bit different, and I've tried to indicate by using a smaller case here that the signals of injury are probably usually a lot less detectable. There's a less favorable signal-to-noise ratio, such that when it comes to looking or imaging for the final phenotype, all we might see are relatively non-specific things, and our ability to understand or detect the cause is limited. So in this slide here, the cartoon suggesting that the tests are negative because we don't know what we're looking for. In fact, what might have been the original cause has disappeared. Our tests such as biopsy are often well within the normal range and don't give us the confidence to make the diagnosis or reject the diagnosis. And it's, I think, still amazing in 2017 that we can have a heart that has such profound disorder, but we still don't know what's caused it. So lesson one, I think, is that we must have a heightened suspicion for myocarditis, or we'll miss it altogether. And it presents via a large variety of pathways. So those baskets that Perry talked about, we've got to really think about things inside those baskets as being different from coronary artery disease, etc., etc., etc. It's also, I think, true to say that myocarditis represents many different diseases. It's not a single entity. It varies in terms of its causes. There are manifold causes, and those causes can have very different consequences, perhaps depending on the host. It's also, I think, helpful to think of myocarditis almost any time you're faced with an idiopathic diagnosis, idiopathic cardiac condition. And myocarditis is one of the, along with inherited heart disease, important causes of idiopathic heart disease. The second lesson is that because of the way the inflammation works, there's a very short early diagnostic window, and some of our tests, including biopsy, MRI, etc., may be least informative when they're most important, that's in chronic disease. So how do we progress with diagnosis? And this is some of the guidance that we receive from the ESC. And Perry, I think, Perry was the chair for this working group document. And I think it's been received as being fairly contentious, because the recommendation here in this document prioritizes the importance of making the diagnosis of myocarditis. And this is the recommendation. It says that all patients with clinically suspected myocarditis should be considered for selective choreangiography and endomyocardial biopsy. So the question then is, should we be doing this? We've been told by the great and learned, that we should be prioritizing making the diagnosis. Should we do this? And so I'll now talk a little bit about biopsy. And this is a representation here of what the endomyocardial biopsy looks like. It's a very invasive test, taking a chunk out of in this case, the right ventricle. And the reason to do this is because you can directly detect evidence of myocardial inflammation as well as myocardial damage. And so the much pilloried Dallas criteria require the demonstration of a lymphocytic infiltrate and myocyte necrosis. And if both of those are present, we'll make a diagnosis of acute lymphocytic myocarditis. If the signal is less florid, we may make a diagnosis of borderline, more chronic myocarditis. And of course, we can detect other really quite important causes of myocardial inflammation, including including sarcoid myocarditis, as well as giant cell myocarditis. And this is really important because the type of inflammatory infiltrate and the ability to detect viral infection, etc., on biopsy have prognostic importance. We've heard from Jerry about acute cardiac myocarditis. I'll say more about that, and also a little bit about giant cell myocarditis. The problem with biopsying is, in addition to the fact it's invasive, expensive, etc., it's not a very sensitive test. And this is a really good, a really interesting experiment done in Stanford many years ago, where I forget how many patients, but individuals who died and on post-mortem were shown to have had acute myocarditis had their hearts subjected to a biopsy protocol in the lab. With a single myocardial biopsy, only 18% of these hearts, or the biopsies, demonstrated myocardial inflammation. And it took as many as 17 biopsy samples before a reasonable diagnostic accuracy is achieved of 82%. This is pretty much near a myectomy, isn't it? And that's using conventional Dallas criteria to make the diagnosis or to interpret the biopsies with. And even if we have an enhanced approach which uses more modern ways of looking at these biopsy samples, looking, for example, for evidence of lymphocytes and typing them, looking for evidence either using PCR or looking for protein of virus, we still don't have a diagnostic accuracy or sensitivity that's really sufficient for our purposes. And one of the reasons that is the case can be shown here on this MRI scan, which is a patient with myocarditis. You can see how discontinuous these myocardial lesions are, and also how epicardial they are. You're not going to approach them if you do a right ventricular biopsy, and a left ventricular biopsy is likely to miss them, but also they're not endocardial, so you may miss them altogether. So we'll then talk about MRI, and Jerry, I think, touched on cardiac MRI, and the reason that we're so excited about the use of cardiac MRI in myocarditis is I've attempted to summarize that here on this slide. And the bottom line is that we use surrogate markers, they're surrogate markers of myocardial injury and inflammation to make a diagnosis of possible and probable myocarditis depending on the pattern of injury and the clinical context with which we're detecting that pattern. So I've got three examples of a heart here: a normal heart, or nearly normal heart, someone who's had a recent myocardial infarct and suffered an aneurysm, an ischemic VSD, and an example of myocarditis. In T2 weighted imaging, you can see there's a lot of water content in the septal and apical left ventricle, in keeping with the infarct. In this case of myocarditis, there's lots of edema in the lateral wall. Looking at early gadolinium enhancement, you can see that this is confluent necrosis here, what's we sometimes term as MVO. It's not so readily visible, but there's, in this area of the heart where the wall is thickened, there's slightly increased signal. This is edematous hyperemic muscle. And then finally, on late enhancement imaging, you see a pattern of scarring that's epicardial. This is not infarct. And so in the right context, this gives you a really good understanding of the diagnosis here is of myocarditis. But that's not the whole story. So these are three more examples of patients with very florid myocarditis. You can see how much water signal there is here. These are thick edematous muscles with all the other evidence of myocarditis that we want to look for. But three very different outcomes. This person recovered completely. His heart now looks completely normal 30 months later. This man's developed heart failure with relatively normal ejection fraction. And this man died suddenly. So MRI is not giving us the evidence or information that's prognostic. And in addition, we are seeing that MRI is not terribly sensitive when we're dealing with less acute presentations of myocarditis. I'm not going to talk too much about what the figures are on this table, but the more chronic the myocarditis is, the less likely MRI is to give us an answer that's either specific or sensitive. Additionally, myocarditis does not tell us what kind of infiltrate is present, so it can't differentiate from lymphocytes, granulomas, etc., etc. And we can't use it to detect the pathogen, the type of virus, for example. And both these features are very important for prognosis, and both of these increasingly will guide how we treat patients with myocarditis. It's a massive limitation to cardiac MR. This is a beautiful slide that Eleanor let me use. And it demonstrates the use of FDG PET scanning and its potential utility also in helping make diagnoses of inflammatory heart disease. And this is an MRI scan of a patient, and you can see from the T2 and the late gadolinium enhancement imaging that there is a big epicardial scar that's non-specific to etiology. And there's no evidence, at least on T2 imaging, that there's a lot of water there. So we would say this person probably didn't have myocarditis. When you superimpose the PET image, my word, suggesting there is a huge amount of inflammation in that area too. We can spend a lot of time talking about really what that means on a biological basis or a molecular basis, but this is a technique that also potentially offers to improve our ability to diagnose myocarditis, and again with the same caveat that we had for myocarditis, except perhaps to say that with PET you also readily identify sarcoid, and I think this is a case of sarcoid, Eleanor. It was. So lesson 3, it's really difficult to confirm I think this patient has myocarditis, and here's the proof. It's difficult to do that. It's also difficult to exclude myocarditis. I have someone with DCM, the results are all equivocal. I can't exclude myocarditis. So none of our tests are great, and we end up spending a lot of time putting things into context, history, having MDT meetings, trying to get to some sort of consensus diagnosis. And this is quite difficult to do. It's a very clumsy way of making diagnoses. Lesson 4. That requires a lot of process, a lot of expertise, a lot of infrastructure. For example, interpretation of myocardial biopsies requires someone to do the biopsy. These sets of skills aren't readily available everywhere, but also in interpreting the results. We've talked a lot about MR, PET scanning, etc., etc. We need new ways to detect myocardial inflammation in a more sensitive and specific way. But we also need to develop better process expertise and infrastructure with what we already know. So what do we actually do in our centre? Essentially, in someone with acutely presenting suspected acute myocarditis, this is the scheme here. And essentially, we're only biopsying, we tend to biopsy only those in whom we think have high-risk features. And those high-risk features are based on an understanding that we want to detect specific causes of myocarditis that have specific treatments. And it's kind of modified from the AHA guidelines for biopsy, which I'll also talk about a bit later. And these are some of the risk features that we would identify, both acutely at presentation, but also during follow-up. Most people don't get biopsied with this presentation. It's very unusual. This is more difficult, and this is a schema for suspected myocarditis in someone with suspected chronic with chronic systolic impairment. And currently what we do is we have an MDT, we do a CMR, we do a PET, and if there's no evidence of inflammation on this, we would treat as nondescript DCM, considered gene testing, etc. But if we think there's evidence of inflammation, this is what we'll do. And the idea here is that there may be different ways of treating patients who have no virus from those with virus. And again, I'll talk a little bit about that later. And again, we don't do this terribly often, and I think it's true to say that we don't often get positive results, even when we think there's imaging evidence of inflammation. So I'll now talk about 2 or 3 cases that illustrate some of those approaches, and the first is a patient who very recently has been managed by us. 41-year-old who was admitted with an ACS, chest pain admission, and of course he had an abnormal ECG, elevated troponin, but unobstructed coronary arteries, and our local protocol now is that these people are considered to have myocarditis unless otherwise proven, and they go through a mill that includes an MRI scan, in his case showed evidence of myocarditis, but also really severe LV impairment. Ejection fraction, I think, was about 20–30%. He had an initial improvement. He got better, both clinically but also biochemically, then had a dramatic deterioration, became rapidly hypotensive, a real classic fulminant presentation with all the features you'd want from that, and became so sick that he was too sick to have a myocardial biopsy, had to receive VA ECMO at Bart's Heart, and then was transferred to Papworth, where he received a BIVAD. And it was at that time, a week or so after he started prednisone, that he had a biopsy, a core biopsy at the implantation of the BIVAD. He did very well, considering, and is now back with us with moderate LV impairment, a non-sustained VT, following supportive therapy. He's no longer on immune suppression. And this is some of his data. So this ECG was obtained. In fact, let's talk about this first. This is his troponin kinetic, starting here at presentation with an extremely high troponin, several thousand. This little red line here is normal. And his troponin initially declined to near normal. He was getting better, and then the second phase of the illness came along here. This is spurious, this. And this is where he went on to VA ECMO. This is where, and received immune suppression. This is roughly about when he got his core biopsy. His ECG shows evidence of widespread myocardial injury. He's lost quite a lot of voltage. He's tachycardic. His MRI stim image shows that he's got impaired LV systolic function. It's fairly regional, though, isn't it? It's mainly apical here in this particular case. It's not true to say that myocarditis is always global. His late gadolinium enhancement imaging is abnormal, but not shockingly abnormal. He's got diffuse late enhancement. But it's his T2 map, which is giving a quantitation of the amount of water we think is in his myocardium, is grossly abnormal, and the values here were 60, 70, where normal is up to about 50, 55. So it's all in keeping with severe myocarditis, but his biopsy result was surprisingly uninteresting, and in the context almost certainly it is of myocarditis, but the pathologist wouldn't have been confident to call this in the absence of all the other information. This is a second case, and this is a man who presented with syncope and palpitations, and an echocardiogram showed asymmetrical septal hypertrophy, and he was diagnosed with HCM, and because of the palpitations, he had a 7-day halter put on, was sent home. He represented on I think on the 7th day, to an A&E with palpitations. They did an ECG, they found him to be in VT, and they shocked him. And all of this is captured on this halter, all of it. He's got hours and hours of monomorphic VT. And of course, when you do the MRI scan, you can see the wall is thick, but it's full of water, abnormal late enhancement. The MRI scan also showed enlarged lymphadenopathy, and a biopsy of his lymph nodes through EBUS demonstrated evidence of acute cardiac sarcoid. His ventricular biopsy, however, was negative. He now has an ICD and is immune suppressed, so specific treatment for this. And this is a much sadder case of a 35-year-old man who had a similar presentation, and the day after he had this MRI scan, he died on the ward, asystolic cardiac arrest, and the post-mortem sample showed evidence of giant cell myocarditis, a condition with a very poor prognosis, but one which is at least partially amenable to treatment with immune suppression. So lesson 5 is myocarditis can and will catch you out. It's a fantastic mimic, and it's very difficult to predict its clinical course. Lesson 6 is that there are several scenarios where myocarditis, having a specific diagnosis, making the diagnosis of giant cell sarcoid fulminant myocarditis, is potentially life-saving, because these things have specific treatments. And we mentioned earlier that the guidance on biopsy from the AHA, etc., is really based on detecting these conditions and treating those conditions. So it's very pragmatic. But we go back to the ESC, and we start talking again about the most important, I think, diagnostic category in myocarditis, and that's chronic dilated cardiomyopathy due to an inflammatory cause. And we have really well developed algorithms and evidence for treating heart failure by dealing with downstream pathways, breaking the cycle of neurohormonal activation, etc., 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 where heart failure begets heart failure. But we do not do anything about this here, the cause of the initial damage or the cause of the continuing damage. And of course, rational therapy really is asking us to see what we can do here, and making a diagnosis of inflammatory heart disease becomes fundamentally important if you consider that approach to therapy. And this is really what the ESC guidance is based on. It's an understanding that if we can identify who has inflammation and what it's caused by, we may get a lot better at treating this condition. And there's emerging evidence in these two relatively small and, as levels of evidence go, relatively low quality evidence. There's emerging evidence also from animal studies that this is a rational and potentially very powerful way of managing inflammatory heart disease. And so lesson 7, DCM is the major challenge to us. I think we'll see increasing use of endomyocardial biopsy and possibly other novel techniques, because it'll become increasingly important to detect inflammation in the heart and evidence of persistent viral infection, because these novel treatment regimes are being tested and become available. And the final lesson, and this is maybe a little bit more contentious, is that we have to become more professional about how we manage myocarditis, how we diagnose it, etc., etc. And doing that properly has lots of implications for infrastructure, for expertise, also for how we organize our health services. And so I think we do need myocarditis centers or networks that work as centers in order to give clinical leadership, to set clinical standards, but also to provide the denominator for clinical research, etc., etc. And that's the final lesson. I would like to acknowledge many people, all my colleagues at Barts, but in particular Ollie Gutman, who's our post-CCT fellow, whose job includes helping us develop our myocarditis pathways better, Ed Stevenson and Alex, I think Alex is here, who are doing PhDs in inflammatory heart disease with us. Thank you very much.